only the salient features from the pulse book questions, the explanations and the synopsis, the important points alone I have compiled all together. First infection is Clostridium infection. So Clostridium is a bacterial infection caused by gram-positive bacteria, and there are four types of diseases caused by four groups of Clostridium species. So they include Clostridium perfringens, which leads to gas gangrene and also food poisoning. But gas gangrene is very important, and the other name for gas gangrene is myonecrosis. So gas gangrene usually occurs in the leg, and it causes brownish to blackish discoloration of the leg, followed by infection which causes release of gas into the tissue and leading to death of the tissue. So it causes necrosis of the tissue, and the treatment for Clostridium perfringens infection, that is gas gangrene, mainly includes antibiotics, sometimes surgical debridement, and also hyperbaric oxygen therapy is being used. So now why I am mentioning so much for this is hyperbaric oxygen therapy is being used for osteoradionecrosis and chronic osteomyelitis. So wherever there is infection which causes any necrosis, you will give an oxygen therapy. So in osteoradionecrosis, because of prolonged radiation, it causes necrosis of the bone. Same way, osteomyelitis is an infection of the bone which ultimately leads to necrosis of the bone. Same way here in gas gangrene also, there is a bacterial infection which causes death and necrosis of the muscle tissue. So in all these three conditions, the common thing which happens is necrosis. So to avoid the necrosis, we give antibiotics followed by an oxygen therapy, which is hyperbaric oxygen therapy. So moving on to other diseases, Clostridium tetani. So Clostridium tetani, we know it leads to tetanus. So tetanus, the classical feature of tetanus includes locked jaw, that is trismus, and then it causes a grin face, which is called as rhizus sardonicus, and stiffness of the body musculature, which is called as opisthotonus. So these are the three features for tetanus, and do not confuse tetanus with tetany. Tetany is caused because of decreased blood calcium level, that is hypocalcemia, and the classical features of tetany includes Schwastek sign, which is twitching of your lip musculature when it is being stimulated. It occurs in the face near the lip region, and you have Trousseau sign, which is a hand which is bent in the shape of an obstetrician hand. When you give pressure in the arms, the hand automatically bends, and that is called as Trousseau sign. So now a recap: Clostridium tetani causes tetanus. Tetanus is caused by a bacteria, gram-positive bacteria. So tetanus leads to trismus, locked jaw. It leads to rhizus sardonicus, which is a grin, expressionless face. Then it also leads to opisthotonus. Whereas tetany is caused by hypocalcemia, and this leads to features like Schwastek sign and Trousseau sign. Now moving on to next Clostridium infection, Clostridium botulinum. Just remember the name, it causes botulism, nothing much is important. Then last one, Clostridium difficile, it causes pseudomembranous colitis. So these are the four important diseases caused by four different species of Clostridium. Now moving on to the next confusing part, that is Rubella, Rubella. These two are very confusing. There is another name which has a common sound, that is Roseola infantum. But Roseola infantum is not important for us as such, but Rubella, Rubella is very important. So both of them, the other names for Rubella is measles, Rubella is German measles. So now very important point for us is the presence of spots. So for Rubella, we have Koplik spots which occurs in the buccal mucosa, whereas for Rubella, there is Forchheimer spot which occurs on the soft palate. It is very, very important, and do not confuse between these two spots. So Rubella, the name is measles, Rubella, it is German measles. And to prevent them in the early childhood itself, we give vaccines. So we have a vaccine called as MMR vaccine, measles, mumps and rubella. So measles is Rubella, mumps is mumps, and then rubella, the other name for that is German measles. So mumps usually causes swelling of the parotid glands bilaterally. So that is a classical feature for mumps. So now MMR, all the three are caused by virus only, but for measles and mumps, it belongs to the group paramyxovirus, whereas rubella, it belongs to the group togaviridae. And the very classical feature for measles, that is rubiola, it is a Koplik spot which occurs on the buccal mucosa. So apart from that, you have maculopapular rash which coalesces, and then clinical signs include conjunctivitis, cough, runny nose and lymphadenopathy. Usually it occurs in the childhood itself. It affects children predominantly. In case of pregnancy, it might lead to fetal death or abortion. Mumps. Mumps, the classical feature is parotitis. After that, apart from parotitis, the other important features for mumps include orchitis and ophoritis, which is a genital organ infection, and then it also causes pancreatitis. Basically, all the glandular infection. Mumps leads to glandular infection. So remember like that. Then lastly, rubella. The other name for rubella is German measles. The classical finding is Forsheimer spots on the soft palate. Then apart from that, it also causes encephalitis and hemorrhagic syndromes. Encephalitis is very important feature for rubella. And one of the common thing for rubella is it usually affects children. And in case of pregnancy, whenever it occurs during pregnancy, the born child will have encephalitis and deafness. It is a very common feature for rubella. So now to brush up, rubiola, rubella. Rubiola is measles, whereas rubella is German measles. Rubiola, it leads to Koplik spots on buccal mucosa. Rubella leads to Forsheimer spots on the soft palate. Next one is hepatitis group of virus. So hepatitis group of virus, we have hepatitis A, B, C, D and E, of which hepatitis B virus alone is a DNA virus. The remaining 4 are RNA virus. And the route of transmission, hepatitis A and hepatitis E is a fecal-oral route, whereas hepatitis C is only the blood transmission, which means any blood infected with hepatitis C, because of blood alone, hepatitis C can be transmitted. Whereas hepatitis B and D, it has both blood as well as other body fluids like saliva, CSF, GCF, urine, everything, all the body fluids, hepatitis B and D get transmitted. And also for hepatitis D, as such, hepatitis D alone cannot straightforwardly affect a person. It is through hepatitis B virus, hepatitis D gets contracted. So again, hepatitis A and E are fecal-oral route, B and D are blood and other body fluids, whereas C is only through blood transmission. Now this slide is a very important slide because there are certain serum markers which indicate certain clinical significance for hepatitis. So here if you see HBsAg marker, which means HBsAg is the first marker to appear in a hepatitis infection. It usually occurs 1 to 3 weeks before the onset of any clinical symptoms. And in case if the HBsAg marker is there for more than 24 weeks, it indicates a chronic infection. So usually HBsAg as such in a broad term means there is presence of infection. Now the next one is anti-HBc, which has IgM and IgG antibody. So here just remember, anti-HBc is a marker of infection. IgM is an acute infection. IgG means chronic infection. Then you have HBeAg. So here HBeAg is very important from MCQ point of view. The reason for that is HBsAg is the first marker to appear in case of an infection, whereas HBeAg indicates there is a active viral replication. So whether it is an acute infection or chronic infection, it doesn't matter. If the virus is replicating, which means the patient is in a very active stage. So the patient is highly infectious. So in case if a patient's marker has both HBsAg and HBeAg, which means it is very dangerous because the patient has a blood which contains these two dangerous markers, which means the virus is highly active. And if that patient accidentally, if there is any blood gets transmitted to another person, HBeAg marker will show you that because a patient has an active viral replication, there are more chances for the victim to easily contract the hepatitis infection. So these are the markers which indicates the severity of the disease for treatment as well as to detect the transmission rate. So HBeAg means active replication. It can be in acute infection as well as in chronic infection. It does not matter, but HBeAg means there is active replication, and anti-HBe indicates there is disappearance of HBeAg obviously, which means the replication has stopped. So the infectious rate will be less in case of an anti-HBe. Whereas the last one, anti-HBs marker, means it occurs usually 3 months after either vaccination or 3 months after a after an infection, which means the antibodies has developed against the HBs. So it can occur post vaccination or post infection. So now to brush up, HBsAg is the first marker to appear in case of an infection. Then you have anti-HBc, which has IgM and IgG. IgM indicates acute infection, IgG indicates chronic infection. Then you have HBeAg, which indicates active replication. It can be an acute or chronic, no issues, but it indicates active replication. Anti-HBe indicates there is reduced virus activity. Then anti-HBs indicates antibody formed against post-infection or post-vaccination. Now next is HIV. So HIV, there are many things to study in HIV. These are the must know important points for HIV. So HIV staging can be done according to the total number of CD4 cells. Now you have to be very clear with two terminologies, HIV then AIDS. Remember, all the AIDS patients are HIV positive, but not all the HIV positives are AIDS patient. Now I repeat again, all the AIDS patients, they are HIV positive, but HIV positive, all the HIV positive patients, they are not AIDS patient. The reason for that is, when a person initially gets a HIV infection, their CD4 count cell will be normal or just slightly reduced. It is not very alarmingly reduced rate. So slowly as the HIV infection progresses, the CD4 cell decreases drastically, and when it goes to a final severe stage, then it leads to a condition called as acquired immunodeficiency syndrome. So as the name states, immunodeficiency means there is reduced immune cells. Acquired, why it is acquired? Because the patient was not born congenitally with immunodeficiency. The patient was healthy. After contracting the HIV infection, the patient has acquired the immunodeficiency. That is, the CD4 cell counts are getting decreased day by day. So it leads to a final stage condition called as acquired immunodeficiency syndrome. So slowly when the CD4 cell counts get decreased below 200, then it leads to a stage called as AIDS. So always remember, if a patient is having a CD4 count, even if the count is 201, then the patient is still called as HIV. As long as any proven severe symptom is there, even if CD4 cell counts are high, then you can term it as AIDS. Otherwise, it is only based on the CD4 cell count you term the patient as just HIV positive or AIDS patient. So now going to the stages. So when a patient is having a primary HIV infection, usually the CD4 cell counts are greater than 500. So the patient will be usually asymptomatic, or the patient will just have a high fever, that is called as an acute retroviral syndrome. So the patient will have a fever of unknown reason for a week or 10 days continuously without any infection, without any reason. The patient will have a heavy fever and the fever will disappear by itself. So that is a stage called as asymptomatic stage or acute retroviral syndrome. Then after that, the patient goes to the stage 1. So during that time also the CD4 count cells will be quite normal only. So the patient will slowly have lymph node enlargement. So it will be a generalized lymph node enlargement. Then slowly all the other lesions will start. So the CD4 cell counts also get decreased day by day. The patient will have mucocutaneous manifestations. There will be recurrent upper respiratory tract infection. then there will be even UTI also. Then slowly it gets, the CD4 cell counts gets reduced even more. The patient will have advanced symptoms. So the patient will have unexplained diarrhea, there will be unexplained weight loss, more than 10 kg of weight loss will be there. Then it might even lead to bacterial infections including tuberculosis. Then finally the patient goes into the AIDS complex where there are severe symptoms which includes many candidal infection. So always remember, whenever there is an immunodeficiency, if there is just a mild immunodeficiency, there will be some bacterial infection. And when the deficiency is so much, which means the body is not able to fight against a foreign organism, the patient will easily land up with severe diseases. So when I mean severe disease, it means fungal infection. So always remember, a fungal infection is a deadly infection, because if you are a normal person, you will not get easily infected with a fungal infection, because your body is so healthy, there are so many immune cells to easily fight against and win the fungal organism. But if your immune system is deranged and if you have severe immunodeficiency, then you'll land up with severe infections like fungal infections. Then it also leads to malignancies like Kaposi sarcoma. So now, how do you group them? The WHO has given some grouping related to clinical stage and laboratory stage. So laboratory stage, how I mentioned, stage 1, if the CD4 cell counts are more than 500, stage 2 is 200 to 500, and stage 3 is less than 200. Clinical staging is category A, category B, and category C. Usually category C goes in line with the laboratory stage 3, and category C has all the AIDS complex symptoms. So as I have already mentioned, A has usually primary infection, asymptomatic, acute retroviral syndrome. B usually has all the bacterial infections, mainly aspergillosis, and fungal infection, you have mild fungal infection like candida. So candida is of all the fungal infection, the simple fungal infection is a candidal infection. The severe ones are deep fungal infections. So when you go to the category C, patient has infections like coccidioidomycosis, then meningitis. Patient will have pneumocystitis, carinine pneumonia, it is caused by a fungal organism, and neoplasms mainly include Kaposi sarcoma. Now going to the antiretroviral drugs. So there are various group of drugs depending upon the viral entry. So starting from the viral entry into the host organism, there are many stages which the virus undergoes. So first the virus goes and binds with the host or organism's receptor. Then it enters the host organism. After that, it binds with the host organism's the genome material. Then it replicates. Then after that, it goes out of the host organism. Then the cycle goes on and on. So depending upon different stages, there are drugs which act at various stages of viral cell replication. So the very first drug is a fusion or entry inhibitor. So if you see in the image, the virus goes and attacks near the entry region. So there is something called as CCR5 receptor. So it binds with the CCR5 receptor to enter the host cell. So during that stage itself, there is a drug which stops the virus entry. So those two drugs are called as enfuvirtide and maraviroc. Then after that, inside, during the viral replication, there are many drugs which include the reverse transcriptase inhibitors and non-nucleotide reverse transcriptase inhibitors. So they all include zidovudin, stavudin, lamivudin, then abacavir, tenofovir, then NNRTI include nevirapine and delividin, etavirin. Then after that, integrase. So it integrates with the DNA material of the host. So during that time, if there is an enzyme which acts to integrate the viral DNA with the host DNA. So if that enzyme is integrase, so there are drugs which stops the activity of integrase. That include raltegravir. So after that stage, it has to go out of the host cell. So for that, there is a enzyme which called protease which acts. So there are some drugs which stops the protease. So they are called as protease inhibitors. So all the protease inhibitors has the name ending as navir. So now to again brush up, you have first is fusion or entry inhibitors. They include enfuvirtide and maraviroc. After that, the viral replication, there are drugs which stop the replication. They include reverse transcriptase inhibitors and non-nucleated reverse transcriptase inhibitors. After that, the formed virus, viral DNA replicates with the host DNA. So it joins with the host DNA. So that joining enzyme, if it stops that enzyme, they are called as integrase inhibitor. Then you have the protease inhibitor. So to easily remember, you can remember the fusion or entry inhibitor, which is the infubitor and maraviroc. Then integrase inhibitor, there is just only one, raltegravir. Then you have protease inhibitor, very easy to remember. All the drugs ends with the name navir. Then the remaining all includes the NRTIs and NNRTIs. So usually in the MCQ, they'll ask you to find out an odd one out. They'll usually mention all the RTIs and they'll ask you to find the odd one out. Most of the time, the odd one will be from the protease inhibitors. So by seeing the name navir, you have to find the odd one out. So here, if the question is going to be tough, where they'll put a check for you in the name tenofovir and abacavir. So because see, all the protease inhibitors, the names are navir, 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 navir. Here, this alone, this usually sounds with the protease inhibitor and the integrase inhibitor, but the name is different. So remember, abacavir and tenofovir alone, though it sounds like as though it belongs to integrase and protease, it belongs to the RTI group. So most of the questions will have the option abacavir or tenofovir. So always remember, abacavir and tenofovir belongs to reverse transcriptase inhibitors. And do not get confused with the name raltegravir also. Raltegravir belongs to integrase inhibitors. Next is the drug of choice for opportunistic infection. So for pneumocystitis pneumonia, the drug of choice is trimethoprim and sulfamethoxazole combination. Toxoplasmosis, again trimethoprim sulfamethoxazole. Then you have any herpes virus infection. Then you have acyclovir, valcyclovir and foscarnet. Cytomegalovirus infection, you can give ganciclovir and foscarnet. All the cyclovir names are antiviral drugs and they are usually given for a herpes group of infection. And then if there is any deep fungal infection, you give amphotericin B. For tuberculosis, it is isoniazid hydrazide, rifampicin and pyrazinamide. For Mycobacterium avium complex, you give rifabutin and ethambutol. Next group of viruses are human herpes virus. So human herpes viruses, there are 8 groups of viruses and there are different names for all the 8 groups of virus. So the first one, HHV1, the name is herpes simplex virus 1. HHV2 is herpes simplex virus 2. Then you have the third virus is varicella zoster virus, which causes chicken pox. Fourth one is Epstein-Barr virus, which which leads to various diseases, of which 4 things are important. The 4 things are infectious mononucleosis, Burkitt lymphoma, nasopharyngeal carcinoma, and oral hairy leukoplakia. Usually, this oral hairy leukoplakia caused by Epstein-Barr virus occurs in patient having AIDS disease. Then cytomegalovirus, herpes HHV6, HHV7, HHV8. Here HHV8 leads to Kaposi sarcoma. That alone, if you remember, it's enough. And HSV1 is important, HSV2 is important, then varicella zoster virus is important. So here for us from MCQ point of view, HSV1 and HSV2. Always remember, HSV1 is above the hip and HSV2 is below the hip. So all the genital lesions will occur because of HSV2 infection, whereas all the oral related lesion occurs in HSV1 infection. So acute hepatic gingival stomatitis is a very common viral infection, herpes simplex virus infection caused by HSV1. And apart from that, there are other infections caused by HSV. They include herpes labialis if it occurs in the lip, herpes gladiatorum. Herpes gladiatorum is an old term. It usually occurs in patient who has any herpes infection in the lip or in the skin region, and this usually occurs in sports player like football players or soccer player. When they play and both the opposite players skin tissue gets in contact, because of that reason the disease gets transmitted. So such type of herpes infection which occurs in sports person, it is called as herpes gladiatorum. Then you have herpetic whitlow. Herpetic whitlow occurs usually in dentists. That happens because of a contraction of herpes infection from oral cavity to finger. So if any herpes infection occurs in finger, then it is called as a herpetic whitlow. No, this gladiatorum and herpetic whitlow no longer happens in this era because most of the dentists, they use gloves. So herpetic whitlow is not happening. And herpetic gladiatorum also, all the sports person, if they get any infection, they usually get treated immediately. So there is no chances like spread of infection from one player to another. So usually these are old terminologies which are used only for MCQ purposes, otherwise it is of no use. Then varicella zoster virus, the primary one leads to chicken pox. The latent recurrent infection leads to shingles or shingles which causes rashes on unilateral side, and the pain will be very severe, and that pain is called as a post-herpetic neuralgia. So post-herpetic neuralgia happens in secondary varicella zoster virus infection, which is a secondary infection of a chicken pox. Next one, disease associated with Epstein-Barr virus. So there are many diseases which research state that there is some association with EBV and all the diseases, but as of now, the more amount of statistics show proven association with EBV with 4 type of diseases. So here, Burkitt lymphoma, nasopharyngeal carcinoma, then in the slide as I mentioned, oral hairy leukoplakia and infectious mononucleosis. So these are very much associated with Epstein-Barr virus. So now there is Burkitt lymphoma and Hodgkin's lymphoma which are associated with EBV. So do not get confused. In the MCQ, if they ask such question, which one should I go and answer for? Go for Burkitt's lymphoma. Then if Burkitt's lymphoma option is not there, so as I have mentioned, these 4 names are important: infectious mononucleosis, Burkitt's lymphoma, oral hairy leukoplakia in AIDS patient, and nasopharyngeal carcinoma. So if these 4 options short confirmed options are not there, then you go for other answers like multiple sclerosis, Hodgkin's lymphoma, like that. So Hodgkin's lymphoma and Burkitt's lymphoma, they both are different. So just a small detail related to lymphoma. Lymphoma, it is a type of cancer that affects lymphatic system, and there are 2 types of lymphoma: non-Hodgkin's lymphoma and Hodgkin's lymphoma. So non-Hodgkin's lymphoma, again, it is classified into various subtypes depending upon the cell of origin, B cell origin or T cell origin, like that. So you have Hodgkin's. Under Hodgkin's, you have lymphocyte predominant and the classic Hodgkin's lymphoma. Then under non-Hodgkin's lymphoma, you have lymphoblastic variant and non-lymphoblastic variant. So under the non-lymphoblastic variant, again you have the T cell B cell variant. Burkitt's lymphoma belongs to the B cell variant. So just remember B for B. Burkitt's lymphoma is a B cell variant of non-Hodgkin's lymphoma. Now, from MCQ point of view, only these are the things which you should study from lymphoma. Burkitt's lymphoma, there is a classical feature for Burkitt's lymphoma, histopathological feature, that is called as starry sky appearance. So there are the cells are distributed as though there are stars in the sky. So the starry sky appearance is a classical feature for Burkitt lymphoma. Then for Hodgkin's lymphoma, the lymphocyte, it is present as though it shows the eye of an owl. So owl's eye appearance is a classical feature for Hodgkin's lymphoma, and the owl's eye appearance is because of the presence of RS cells, or also called as Reed-Sternberg cell. So remember, owl's eye appearance or Reed-Sternberg cell is present in Hodgkin's lymphoma, whereas starry sky appearance is present in Burkitt lymphoma, which is a type of non-Hodgkin's lymphoma. Then in this Reed-Sternberg cell, the classical one is called as the RS cell or the owl's eye appearance. And there are many variants of RS cell, of which the very important variant is the last one, that is popcorn cell. So in the Hodgkin's lymphoma itself, there is a type called as nodular lymphocyte predominance type. So when there is a nodular lymphocyte predominance type of Hodgkin's lymphoma, the lymphocytes, they coalesce and form something, they resemble something like a popcorn. So instead of a classical owl's eye appearance, there are multiple lymphocytes which coalesce and form something which resembles a popcorn cell. So just remember, popcorn cell and RS cell, they are present in Hodgkin's lymphoma. To be specific, the classical RS cell is a owl's eye appearance. A variant of RSL, which is a popcorn cell, is found in a nodular lymphocyte predominant type of Hodgkin's lymphoma. These are the things which you should mainly read from lymphoma. Then again, moving on to our infection part. So these are the main drugs, antiviral drugs, important drugs which you should know. So for any herpes infection, anti-herpes viruses, the drugs include acyclovir, valcyclovir, famciclovir and ganciclovir. These 4 names. Then foscarnet, 5 names. If you remember, that is enough. Any anti-influenza virus, you have to remember oseltamivir and zanamivir. Then for hepatitis infection, anti-hepatitis B, you have lamivudine, very important drug. For hepatitis C, ribavirin and interferon alpha. Just remember, whenever any viral infection which is quite prolonged, a chronic viral infection is there, then interferon alpha comes into play. So if it is a very acute viral infection as such is only acute. But in case if a viral infection is quite prolonged, then we give interferon alpha also. So in case apart from this hepatitis C, ask even in COVID also, if it is a prolonged infection, we usually even give interferon alpha apart from other drugs. So any terms like hepatitis C or newer antiviral drugs name is there, search for words like interferon alpha. Next one is related to cerebrospinal fluid and its feature in various infections. So you have mainly 3 groups of infections: bacterial, viral and fungal. Then the normal feature of cerebrospinal fluid. So cerebrospinal fluid, you have to search for protein and glucose level. So usually in case of a bacterial infection, mainly bacterial infection, there is tuberculosis meningitis. So to search for tuberculosis meningitis or any acute viral meningitis, you have to search for the presence of glucose and the presence of protein. So if the protein levels are high, then it is tuberculosis meningitis. If the protein levels are normal, then it is usually indicative of viral infection. And also after seeing the protein value, you have to see for glucose value. So for glucose value, it is normal in case of a viral infection. In case of a bacterial infection, mainly the tuberculosis bacterial infection, the glucose levels are low. So remember, the protein and glucose level is normal in a viral infection. For a bacterial infection, the glucose level is low and the protein level is high. Next one, for cerebrospinal fluid, to detect the presence of cerebrospinal fluid, that is in case a patient goes into a fracture, the patient will have bleeding through the nose. So bleeding through the nose, usually if there is any rupture of blood vessel, the patient will bleed. So apart from just the bleeding of bleeding of blood, what if there is cerebrospinal fluid leakage? So through the nose, along with blood, there are chances of cerebrospinal fluid leakage also. In that case, you have to repair it to avoid further complication. So now how do you find out whether it is just plain blood or the blood is also containing cerebrospinal fluid? So if the blood is also containing cerebrospinal fluid, then it is called as a cerebrospinal fluid rhinorrhea. Or sometimes usually even without blood, the patient might have a bleeding through the nose. So it can be just a plain nasal discharge as well, or it might be CSF rhinorrhea. So how do you differentiate them, or how do you find out it is CSF? The classical test to check the presence of CSF is by the presence of beta-2 transferrin. So remember the word beta-2 transferrin. If you find the word beta-2 transferrin in the option for the presence of CSF, then it is indicative or positive for CSF rhinorrhea. So if it is just a blood, beta-2 transferrin is negative. If it is a nasal discharge, beta-2 transferrin is negative. Only for CSF, presence of CSF, then beta-2 transferrin is positive. So just to find out the presence or absence of CSF, you check for beta-2 transferrin. And after finding out CSF, or in case of any infection, you wanted to know why what type of infection is there in the brain, so that you treat accordingly. you do a CSF analysis with different parameters. So under that condition, you check for protein and glucose to find out the differentiation between a bacterial infection and a viral infection. So in case of viral infection, the glucose and protein levels are normal, whereas in case of a bacterial infection, the glucose level is low, the protein level is high. In case of a fungal infection, the glucose is usually normal or low and the protein is high. So which means if there is any infection, that is bacterial or fungal infection, the features are quite similar. That is, glucose is low and protein is high. Whereas if it is viral infection, it resembles the normal findings like a normal glucose level and the protein level is also normal. Next one is syphilitic infection. So for syphilitic infection, you have three stages of syphilis: primary syphilis, secondary syphilis and tertiary syphilis. So primary syphilis, the main manifestation is a chancre. So chancre, remember, it is usually painless, but if it is quite deep, it is painful. And always remember, chancre in the genital region is usually painless, but if it is an oral chancre, it is 90% of the time it is a painful lesion. Then you have secondary syphilis. So secondary syphilis, you have mucosal patches. All the ulcer, this ulcer, if it is a solitary ulcer, there are multiple ulcer which coalesces. If the ulcers join, they form something called as a snail track pattern. So always remember, snail track ulcer is a classical feature of secondary syphilis. Apart from that, it also has leukoplakia like plaques and maculopapular lesion, syphilitic glossitis and condyloma lata. Then for tertiary syphilis, the features are gamma, then atrophic glossitis and syphilitic leukoplakia. So syphilitic glossitis, which is the inflammation of the tongue, it is sometimes overlapped in secondary syphilis as well, or it might be present in tertiary syphilis. Just remember, a late secondary syphilis will lead to syphilitic glossitis. Then you have a very important one, congenital syphilis. So under congenital syphilis, you have early manifestation and late manifestation. So late manifestation is very, very important because we have a classical three features triad of feature which is called as a Hutchinson triad. So Hutchinson triad includes Hutchinson incisors. It's not only incisor that gets affected, there is molar also which gets affected. So the incisor is called as a screwdriver shaped incisor and the molar is called as a mulberry molar. So the incisor and molar together are called as Hutchinson's teeth. And Hutchinson's teeth usually manifest as Hutchinson's incisor, but that doesn't mean molar is never affected. Molars also get affected and the affected molar is called as a mulberry molar. Apart from that, the other feature which belongs in Hutchinson triad include interstitial keratinitis and the eighth nerve deafness. The early manifestation of congenital syphilis include syphilitic rhinitis, hepatosplenomegaly, then there is vesicular or bullous eruptions on the leg, and there is something called as raggeds. So RHAGHADS. So raggeds is a radiating scars which is present around the mouth, nose and anus. This is another feature for early congenital syphilis. Next one is tuberculosis. So tuberculosis is caused by Mycobacterium tuberculosis, a bacterial infection. So as soon as the patient gets the infection, there are various manifestations that can happen. So first is the patient will have a primary tuberculosis, a lung infection. So after the primary tuberculosis, most of the time, 90% of the cases, the patient will have a healing which is followed by fibrosis and there are calcifications that happens, and when the primary tuberculosis gets reactivated, it is a secondary tuberculosis. This is the usual course of a tuberculosis. But unusually, some 10% of the cases, what will happen is from the primary tuberculosis, the patient will go to a progressive primary tuberculosis, which means the infection will become even more severe and it will be associated with other opportunistic infections like fungal infection. The patient will have severe infection. Usually this progressive primary tuberculosis happens in condition where patient is having severe malnutrition or severe immunodeficiency like AIDS condition. So after this progressive tuberculosis or from the primary tuberculosis, the patient when it gets reactivated, the patient might end up with the organisms entering the bloodstream. So once it enters the bloodstream, it is called as a bacteremia. So after entering the bloodstream, it can affect various organs of your body. So the various organs include, if it involves multiple organs, small calcifications happens in the liver, kidney or other glands. They are called as miliary tuberculosis. So when it occurs in the bone, when it affects the spine, it is called as a Pott's disease. Now, again coming to the primary tuberculosis. So, usually in primary tuberculosis, what happens is the primary tuberculosis affects the lobes near the middle or the lower lobes, whereas the secondary affects usually the upper lobes. This is another feature for TB. So, the primary ones usually affects the mid or lower lobes. So, when the infection occurs in the lung lobes, usually when it involves the middle or lower lobes, that group of infection, the clubbing of infection, that is called as a Gons focus. Then obviously when there is an infection, there is a lymph node enlargement or any lymph node involvement. So when the infection also reaches the regional lymph node, for lung the regional lymph node is a hilar lymph node. So when the infection is there in the lung, it is called as a Gons focus. When it is involving the lymph node, the term Gons complex will be used, because there is lymph node, there is infection in the lung as well as in the lymph node. So Gons focus plus the hilar lymph node involvement is called as a Gons complex. Now there is something called as rank complex. So rank complex is nothing but, see, Gons focus is in the lung. Gons focus plus hilar node is called as a Gons complex. In the Gons complex, when there is any calcification that happens, then it is called as a rank complex. So these are the stages. So initially there will be just Gons focus. Then the infection goes to the nodes, so it leads to Gons complex. Then it progresses and leads to calcification, which leads to rank complex. So these are the different terminologies which are there from MCQ point of view, which is very important for tuberculosis. So now, after the patient goes into the secondary stage, there are infection that usually, if it involves the lung, it usually involves the upper nodes. If it involves the other organs, you have miliary tuberculosis, and if it is a spine, you have Pott's disease. Now there is a terminology called cold abscess and cholesterol abscess, then scrofula. So what is a scrofula? So as I have mentioned, it enters the bloodstream, bacteremia. So from the bloodstream, it can go to various organs. So like that, if it involves other lymph nodes, not the regional lymph node like hilar nodes, but it involves other nodes like cervical lymph node or other nodes, whenever the tuberculous bacteria involves a lymph node infection, that is called as a scrofula. So scrofula of the neck is called as a cold abscess. So how the scrofula occurs is, first the organism goes and attacks the lymph node. So it goes to lymphadenitis. Then slowly the lymph nodes gets matted. So there is a matting of lymph node, and the palpation, you can see rubbery kind of palpation. So that is a classical feature for tuberculous lymph node. So after that, after coalescing, it slowly leads to the abscess and necrosis formation. That is called as a cold abscess. Why it is called as cold abscess? Because it is there deep inside, and there is when you touch the swelling, when you palpate it, there won't be any warmth present, because for any inflammatory swelling, when you do a palpation, the warmth will be there. That is a classical feature for inflammation. Whereas in case of a tuberculous swelling, when you do a palpation, when you just touch it, it will be cold. That is why it is called as a cold abscess. So it is there in the deeper tissue. Then slowly from the deeper tissue, it goes to the superficial region where it bursts out. So before bursting out, the stage where from the deep fascia to the superficial fascia, there is movement of lesion, then it is called as a collar stud abscess, because it looks like a collar stud. Then after that, it bursts out forming a sinus. That is a sinus formation. So these are the stages of scrofula, which is a tuberculous lymphadenitis. Now, antitubercular drugs. So antitubercular drugs, you have first line group of drugs and second line group of drugs. First line of drugs involves 5 drugs, which are isoniazid, rifampicin, ethambutol, pyrazinamide and streptomycin. So here the side effects of antitubercular drugs are very important. So isoniazid, is a bactericidal drug, rifampicin is a bactericidal drug, ethambutol is a bacteriostatic drug, pyrazinamide and streptomycin is bactericidal drug. So the only drug in the first line of drug which is a bacteriostatic is a ethambutol. Now coming to the side effects. So side effects, isoniazid has hepatotoxicity and peripheral neuropathy, rifampicin hepatotoxicity, reddish orange discoloration of urine. Very important point. It is a classical feature for rifampicin. The side effect is reddish orange discoloration of urine. For ethambutol, the side effect you have retrobulbar neuritis and hyperuricemia. Then for pyrazinamide, again you have gout and hepatotoxicity. Streptomycin, very important. So streptomyces, the patient will have ototoxicity, vestibular toxicity, cochlear toxicity, which means the patient they have tinnitus problem. Then there is nephrotoxicity. So if you read all the toxicity, all the drugs, there are words like hepatotoxicity. So remember, any drug, it will cause liver damage. So hepatotoxicity is not a very classical feature for a particular drug, because many drugs like nausea and vomiting, the adverse effect for a drug is hepatotoxicity. So after hepatotoxicity, there is a word nephrotoxicity. So remember, hepatotoxicity is not a very classical feature, whereas nephrotoxicity is classical for streptomycin. So that drug you have to remember. And for rifampicin, reddish orange urine is a classical feature. So you have to remember. So antitubercular drug side effects is very important for all the drugs, of which rifampicin side effects and streptomycin side effect is very important. Next is DOTS regimen. So DOTS regimen, you have two groups of patient, category 1 and category 2. Category 2 usually involves the relapse patient and any drug resistant patient. So category 1 duration is 6 months, category 2 is 8 months duration. The regimen has HRZE for 2 months and HR for 4 months. Just remember, for the category 1, it is usually the first line of drugs. You have all isoniazid, rifampicin, then pyrazinamide and ethambutol. Then in the category 2 alone, you will include the streptomycin drug. Streptomycin is usually not given in the first line, the category 1 patient, because it has lot of side effects. Because of that reason, for the category 1 patient, when it is very initial lesion, you do not go to the streptomycin drug. After if the disease is very severe or there is any relapse, then only you select the patients like streptomycin. Next is streptococcus infection. So streptococcus, you have streptococcus pyogenes, that is group A streptococcus, then you have group B streptococcus, then other beta hemolytic streptococci. And these are the infection caused by streptococcus, of which the streptococcus pyogenes infection is very important. So it leads to various conditions, pharyngitis, scarlet fever, cellulitis, streptococcal toxic shock syndrome, rheumatic fever, and post-streptococcal glomerulonephritis. So streptococcus species, you have alpha and beta, then you have the gamma one, which causes no hemolysis, of which the beta hemolytic streptococci, under that the group A streptococci, which is streptococcus pyogenes, is the most important one for us. So streptococcus pyogenes, it causes various infection. So it can cause pharyngitis, it can cause even bone infections like osteomyelitis, arthritis and meningitis. The direct toxin, when it gets affected, it leads to scarlet fever. And streptococcus pyogenes as such, if it acts as a foreign body, it leads to, it triggers the immune system, leading to various conditions like rheumatic fever, or if it involves the kidney, it causes post-streptococcal glomerulonephritis. So now rheumatic fever. Rheumatic fever, it causes, there are various features associated with rheumatic fever. So you have something called as a major criteria and minor criteria. That is called as a modified Jones criteria. So other name for modified Jones criteria is Duckett-Jones criteria. So major criteria includes cases which is carditis, arthritis, subcutaneous nodules, erythema marginatum and Sydenham's chorea or Saint-Witter's dance. And the minor criteria includes FRAP is a mnemonic, which includes fever, raised ESR, arthralgia, prolonged PR interval and previous rheumatic fever history. So there should be, patient should be infected with streptococcus infection. Apart from that, any two major criteria or one major criteria and two minor criteria gives a diagnosis of rheumatic fever. Now, infective endocarditis prophylaxis. So, why do we give infective endocarditis prophylaxis? Because most of our dental caries, the dental infection, the dental caries is caused by streptococcus viridans. So, there are many streptococcus species which are involved in dental infection. So, if a patient already has a history of endocarditis, or if a patient is having any valvular surgery or valvular condition which the patient has had already, there are many chances for the streptococcus species to easily enter the bloodstream and cause infections like rheumatic fever. So, to avoid that reason, we give infective endocarditis prophylaxis. So, prophylaxis, the standard prophylaxis is 2 gram of amoxicillin 30 minutes before the procedure. In case if the patient is allergic to amoxicillin, you give 600 milligram clindamycin or 500 milligram azithro. In case if the patient cannot take it through oral route, you give 2 gram ampicillin as IM or IV, or if the patient is having penicillin allergy and also oral intolerance, then you go to clindamycin 600 milligram IV route or cefazolin 1 gram IM or IV route. Now, next is to just brush up the group of antimicrobial drugs. So, antimicrobial, depending upon the mechanism of action, you can group all the antimicrobial. So, first one, beta-lactam antibiotics, which includes the penicillin cephalosporin, they stop the cell wall synthesis. Then DNA gyrase metabolism, if they stop during that stage, the drugs which belong to the DNA gyrase group, it includes quinolones. Then another one is protein synthesis inhibitor is very important. So, protein synthesis, you have 50S subunit and 30S subunit. Remember the mnemonic 80-30. 80 belongs to aminoglycoside and tetracycline. So, 80-30 aminoglycoside and tetracycline, they mechanism of action is 30S protein synthesis inhibitor. Then the remaining one, erythromycin and chloramphenicol, is 50S subunit inhibitor. Only so much if you remember, at least if you are a beginner, it is more than enough. Next one, some summary of antibiotic side effects. So, as I mentioned, there are many side effects. The classical one like nausea, vomiting, hepatotoxicity is present in almost all the drugs, but there are some classical side effects which are specific for certain drugs. So, they include for aminoglycosides, it is ototoxicity and nephrotoxicity. So, under aminoglycoside, you have streptomycin. Then we have tetracycline. Tetracycline photosensitivity is very classical. Then after that, tetracycline yellowish discoloration of the teeth is very important. And then for macrolides, it is QT interval prolongation. For fluoroquinolones, it is tendon damage. Vancomycin, it leads to Redman syndrome. Nitrofurantoin, there is brown colored urine. Then for linezolid, there is serotonin syndrome. Penicillin usually leads to allergic reactions. So there is any penicillin allergy, usually it leads to hypersensitivity reaction. Then you have clofazimine, brown or pink skin discoloration. For isoniazid, it is peripheral neuropathy. So, of which the important ones which you should remember is penicillin, isoniazid, vancomycin, macrolide, tetracycline and aminoglycosides. Next one, the drug of choice for various conditions. So, if there is any streptococcal infection, the drug of choice is penicillin. For staphylococcal infection, it is dicloxacillin. For pharyngitis, again it is penicillin. In case of pneumonia, it is clindamycin or doxycycline. For any UTI, it is fluoroquinolone. For gastroenteritis, it is ciprofloxacin. Then for syphilis, primary syphilis, it is usually penicillin, benzathine penicillin. Any neurosyphilis, that is the tertiary form of syphilis, you give aqueous penicillin. So just remember, penicillin is the drug of choice for most of the bacterial infection. Next, the drug of choice for other infection. For any parasital infection, just remember few words, the drug names. Whenever any parasital infection, parasite I mean any worm infection, they all belong to parasite. So ringworm infection, tapeworm infection, roundworm infection, flukes, all these are parasites. So if there is any parasite infection, you have only 3 or 4 main drugs which are the drug of choice. So they include albendazole, mebendazole, metronidazole, ivermectin and praziquantel. So these are the 5 drugs which are the drug of choice for almost all the parasitic infection. So search for the word albendazole or mebendazole. Then if those 2 names are not there, definitely ivermectin will be there. So these are the parasitic, anti-parasitic drugs. Then some drug of choice for antifungal infection. So when there is any antifungal infection, immediately the fungal infection which is very important for us is candidiasis. So candidiasis is a very superficial fungal infection. So just a topical drug is enough. So you can give topical clotrimazole, that is more than enough for candidiasis. But in case of other deep fungal infections like say mucormycosis or coccidioidomycosis or any other deep fungal infection, usually we go for amphotericin B. So amphotericin B, there is topical as well as systemic route, but if there is a deep fungal infection, you go for systemic route. And usually they have all the antifungal drugs. Remember, a systemic antifungal drug is highly toxic. So whenever there is fungal infection, when it is just a very simple superficial fungal infection like candidiasis, 100% you will not go for systemic treatment. You have to treat it only by topical. The reason for that is all the systemic antifungal drugs are definitely toxic. So you have to check for the benefit for even if you give the toxic drug. The reason why you should give is if you don't give the drug, the patient will die. Only during that condition only you have to go for a systemic antifungal drug. So the main systemic antifungal drugs include amphotericin B. After that you have nystatin also. So these are the two systemic antifungal drugs. They are available in topical form as well. So you go for topical. If it is not getting subsided, then you go to the systemic variation. Next one is mucormycosis. So mucormycosis is a fungal infection. It is a deep fungal infection. It became quite famous because of COVID-19 infection. So reason for that is mucormycosis is a fungal infection which requires more amount of iron content. So whenever the patient when the patient got treated for COVID-19 infection, usually the prescription for COVID-19 often had the multivitamin supplements which require zinc. Zinc is good, but a zinc supplement which had iron formulations along with it increased the available iron in the blood. So this helped growth of the fungal organisms easily. Because of that reason, the patient ended up easily with mucormycosis. And also steroid. Why steroid? Steroid suppresses the immune system. So as I have already mentioned, whenever the immune system is suppressed, the patient will easily acquire fungal infection. That is why in AIDS complex is not, patient easily gets fungal infection. So whenever the patient is diabetic also, the patient's immune system gets alterated. So before COVID, the mucormycosis was very classical for patient who had uncontrolled diabetes mellitus. So the reason for that is whenever a patient has uncontrolled diabetes mellitus, the patient's glucose level gets increased so much and the patient will end up with diabetic ketoacidosis. And whenever a patient has diabetic ketoacidosis, the blood serum iron levels gets drastically increased for such patient. When the serum iron levels get increased, the fungal organism will easily thrive in such condition. So because of that reason, the patient will easily end up with mucormycosis. And the mucormycosis of the oral cavity, very typical feature is perforation of the palate. So the patient will have a very severe ulcer with sloughing of the mucosa. There is exposure of the bone and there will be perforation of the palate. So these are the classical feature for a mucormycosis of the palate. So we are done with today's discussion as such. I have covered almost all the infection part for today's session. These are the very important things from infection which you should study. You have to study it together along with general medicine, general path and pharmacology. We'll see some more session from general medicine. The remaining systems like hematology, one full day will allot for hematology where I'll be clubbing the physiology, general medicine and the other aspects of hematology. So from infections point of view, so much whatever I have mentioned, if you have brushed up, it is more than enough. We're done with today's session. Thank you.